Guys, this is Dr. Mobeen from drbean.com. Today we will continue our discussion, and I wanted to talk about the dexamethasone. So there was a study yesterday that was about the dexamethasone use in COVID-19 patients and the outcomes that they had. So I thought that we should, number one, go over that study, and number two, understand the mechanism of steroids once more, especially in the context of dexamethasone, and then to understand what are the side effects and what are the benefits that it presents. So with this, let's start. I'm going to share my screen and let's go over the study. If you see the study over here, this is the recovery trial by the University of Oxford. There are some good and bad things here. The good things are, number one, it is by Oxford, which is a reputable, well-established, respected institute. So we should be able to say that, hey, they have done something good. And something coming from them should be trustable. That is one. I'm contrasting that to Sergi Sphere, for example, which was not an entirely a reputable organization. So compared to that, Oxford is, of course, a million times better. So that is one good news. The second good thing here is that over 11,500 patients have been enrolled from over 175 NHS hospitals in the UK. So the cohort size is a very large size. And out of that, a total of 2014 patients were randomized to receive dexamethasone. So even that number is a very decent number. So from this point of view, the study looks very good. From what is my discomfort at this time, it is the same as we saw with the Moderna or with Sergi Sphere, and that is that the data itself is not yet available. This is a note, this is a statement from Oxford. It is not a study publication itself. So maybe they need time to put that publication out, but meanwhile, we have to stay alert that just like Moderna did, there was no data, but they had a news cycle. Or just like Sergi Sphere did, where the whole world stopped using the hydroxychloroquine, and the WHO reacted, and so many other news cycles started, which have caused so much damage. So again, this is a study which doesn't have data published yet. We can trust Oxford to not come up with something fake here. So hopefully what they're saying here is good and beneficial. So now let's look at the study. Study says on 8th June, recruitment for the dexamethasone arm was halted since they had enough people. So that is one thing over here. A total of, so if you look at this part, a total of 2014 patients, 2,104 patients were randomized to receive dexamethasone. Look at the dose here, 6 milligram once per day, either by mouth or by intravenous injection for 10 days, and were compared with 4,321 patients randomized to usual care alone. So that is a very important thing here. They had about 2,100 patients in the treatment group and 4,000 in the control group. Among the patients who received usual care alone, 28-day mortality was highest in those who required ventilation. So if you see here, 41%. Intermediate in those patients who required oxygen only, 25%. And lowest among those who did not require any respiratory intervention. So what they're saying is that people who did not need respiratory support, they had the best outcome. Then those who were on oxygenation, they had the second best outcome. And then the patients who were on ventilators, they had the worst outcomes. Now look at this. Dexamethasone, the one that I've made green over here. Dexamethasone, let me see if I can make it bigger. It does not. Dexamethasone reduced deaths by 1/3 in ventilated patients. This is a remarkable number. Rate ratio is this, confidence interval is that, and by 1/5. So in ventilated patients, 1/3 were saved, and by 1/5 in other patients receiving oxygen only. So you can see that dexamethasone's effect is reduced if somebody is on oxygen only, and it has a better response when somebody is on ventilator. And then if you continue reading it, there was no benefit among those patients who did not require respiratory support. So somebody who did not require respiratory support did not have any benefit from the drug itself. So I wanna make sure that we understand a very important point here, and that is that steroid use in the early part of the disease is quite damaging because it can suppress the immune system, resulting in the virus to replicate fast and cause disease with severe intensity. However, once the patient is in ICU, is dependent upon oxygen, or is on ventilator, their basic problem is not the virus anymore. Their basic problem now is the immune system that has gone nuts. I always call it immune system that has gone nuts, that has gone in disarray and is responding overwhelmingly and causing the cytokine storm and the acute respiratory distress syndrome, and then septic shock, and then death. So it is the immune system that needs help, and that is when the immune system is gone bad, and that is when we are in ICU or on ventilator. This is why this drug, the steroid use, is not indicated in the early part, and so please do not use it in the early part and cause issues. So this is the discussion. They said that while we are still working with the study and probably collecting the data, we wanted to bring this statement out so that public health is important at this time, and so you can benefit from this data while they would publish the whole study. So that is the study itself. Now, let's look at, so there are a couple of questions. So those folks who just wanted to understand what is going on with the study, I think this much is the discussion for them. Now I'm going to go into the details for the steroids itself and talk about the steroids function and doses, types, and then side effects. So let me just quickly see here. There is a comment, Mbal, they don't die, but what were they living with at this time? I do not see the, okay, so I can't make out the comments yet just because I just looked at it. So Dr. Drake says that those drawings are adorable. So thank you very much. I spent a lot of time working on them. So let's look at these drawings. So now we have looked at the study. The important thing is that 1 out of 8 people on ventilators is saved by dexamethasone, and that is a reliable, statistically significant observation. So this is why there is so much of news around this, that this is the first drug where without any doubt it has shown a reliable outcome. And then 1 in 25 patients on oxygenation had better outcome. So somebody had tweeted to me and said, what's the use of 1 in 8? So look, that is a percentage, that 1 in 8, or as you saw the percentage over here, that they were saying 1/3 in ventilated patients. So they're saying that 1 death would be prevented by treatment of around 8 ventilated patients. Every single patient saved is very, very important. And if we can have 1 death prevented out of 8, maybe we can start using it in various ways or combining it with other things to actually continue to build on it and reduce further deaths as well. So it's a great study. It's a great outcome. So let's look at the corticosteroids themselves. So I'm going to go over this as fast as I can. Look, corticosteroids are produced by our suprarenal glands. So suprarenal glands are sitting on top of our kidneys. This kidney I made a little bloated. So they are sitting on top of our kidney. This is the suprarenal gland. And suprarenal glands have 2 parts, cortex, which is the outer part, and then medulla, which is the inner part. It is the cortex we are talking about. So if you look at this drawing over here, this is the histological picture, but mainly what I'm trying to present here is that cortex, which is this part, cortex is further divided into 3 zones. We call zona glomerulosa, zona fasciculata, and zona reticularis. And when I used to be in medicine, we used studying medicine, we used to say the deeper you go, the sweeter it gets. That mnemonic is to know uh, what kind of substances are released. So outside zona glomerulosa, that releases mineralocorticoids. So mineralocorticoids are steroids that are responsible for electrolyte balance, for example, sodium and potassium and water. So of course, sodium is salty, so it is not that sweet. Then if you go to the second zone, that is zona fasciculata, which is here. This zone is responsible for releasing glucocorticoid, which are also steroids. And glucocorticoids function is to work with carbohydrate metabolism or with sugars. So that is why it has become a little more sweet. And then zona reticularis, which is the innermost part of the cortex, that releases androgens, which are sex hormones. And so that is the sweetest part of the cortex functions. And then as you come into the medulla is actually a kind of specialized neuronal cells or nervous system cells. They release catecholamines, which are norepinephrine and epinephrine, and take part in other functions of the body that are very important too. So this is the corticosteroid from where these are released. Now let's look at how corticosteroids are released. Normally in stress response, their release is increased. So what happens in that case is, look, fear. So nowadays with COVID, there is fear. So fear, pain, injury, hemorrhage, bleeding, surgery, major surgeries, hypoglycemia, infections, which again, COVID-19, cold, and so on. These stressful situations can cause these stressful situations can cause release of corticosteroids or steroid hormones. Now, we do not know exactly the mechanisms for each one of them, that how do they trigger the release of the steroids, but the end result of release is that steroids then come in and prepare our body for better protection and better responses. So before we continue, I wanted to make sure that we look at the types of steroids, because if you remember Math Plus protocol had used methylprednisolone in its protocol. So look, the steroids can be divided into three main categories: those which are short acting steroid and less potent, then the intermediate acting and slightly more potent, and then long acting and very potent. So if you see here, hydrocortisone and cortisone, they are short acting steroids. The potency of hydrocortisone is used as the baseline. Cortisone is 0.8 of that, and they are both short acting and less, I would say, relatively less harmful. They are less beneficial as well. Then, as we continue, prednisone and methylprednisolone, on the other hand, their potency is about 5 times of the hydrocortisone. So 5 times more potent, and they are intermediate acting. And finally, dexamethasone here and betamethasone, they are 25 times more potent than hydrocortisone. 25 times more potent. Times, it's not percentage, times. So it's very, very potent drug. So it should be used with care. The biggest problem with this, which if somebody is self-medicating, if they used it and then they abruptly stopped it, it can be lethal, because the adrenal insufficiency can occur, which is acute insufficiency, and can kill the person. So steroids have to be tapered down and reduced in dosage so that the suprarenal insufficiency is not a problem. Continuing here, very quickly, let's look at the mechanism of actions. The way I am working on this one is that instead of going in detail for every single area's mechanism of action, which can take months to discuss steroids, I'm going to specifically talk about immune system, but I'm just going to touch on the other systems and the effect of steroids there. So first of all, here if you see this diagram, what happens is that steroids, this guy here, steroids are normally found bound to proteins, albumin and cortisol binding globulin. These proteins are released by liver. Steroids sit on them or bind with them. Then when they reach their cell where they have to act, what happens is that steroids will get into the cell and they would bind inside the cell. There are, in the cytoplasm of the cell, there are receptors to bind with steroid. Then that receptor and steroid complex would go into the nucleus. In the nucleus, they would combine with various genes to mostly activate the genes. However, in some cases, they inactivate the genes as well. For example, our discussion today is mostly about the immune system, and many of the steroid actions on the immune system are suppressive. That means they actually block the gene expression. But many other of the functions can actually enhance the gene expression. So having said that, let's look at their actions. So one action is on the glucose metabolism. So basic thought, the basic purpose of a steroid hormone is to try to get us energy for our brain and muscles when we are under stress. So what they do is they ask the liver to make new glucose, which is called gluconeogenesis. They break down lipids to create glucose from them as well. They stop utilizing glucose. They stop the tissues from using glucose in other areas than brain and muscle. So as they increase the glucose levels, the purpose of that is that muscle and brain are about to be using them, but the rest of the tissues are stopped from using it. So that is the action for carbohydrates and proteins. Then on the lipids, the fats, steroids cause a fat redistribution. And what happens is that the fats start accumulating on face, on the back, and above the clavicular areas. So that is called moon face or buffalo hump or supraclavicular fats. At the same time, the fats and the muscle of the extremities, they start breaking down. So the person has a very interesting specialized habitus, which we say steroid habitus, where their extremities, their limbs are thin, but their truncal area is more obese. And even in that, the upper parts are more obese than the rest, or more fatty than the rest. At the same time, steroids also increase free fatty acids. So that is the action on the lipids. Then here is their action on the renal system. What they do is, so this is the electrolyte action, that is mineralocorticoid. So what they do is they preserve sodium, with which water will be preserved as well. So they would increase the blood pressure and blood volume. They, in exchange for preserving sodium, they tend to throw out potassium and hydrogen. An extra throwing of hydrogen out will cause alkalosis. Similarly, the glucocorticoid part can throw out a lot of calcium, which causes hypocalcemia. In addition to that, glucocorticoids can also cause increased free water production, so water wastage can occur. So that is a fluid and electrolyte action. Then, if we continue, on the cardiovascular system, prolonged use of steroids can cause fibrosis of the heart. It can cause damage to the heart, where the heart muscle itself is now replaced by fibrous tissue, which would slowly not function correctly and the heart would fail. The other thing that they do is that they can cause vasoconstriction. This is in sync with trying to keep the blood pressure and blood flow going. So really blood pressure. So hypertension can be caused by them, and cardiac fibrosis can be caused by them. On the muscles, they can cause fatigue. Prolonged use can cause fatigue and wasting. On the CNS, steroids' presence keeps our mood balanced and our behavior correct and our excitability normal. If we give extra steroids, that can actually cause behavioral disturbances. People can become hyperexcitable. When these steroids are left or reduced, then they can become depressed. So there can be behavioral issues. With this, so I kind of plowed through all of that very quickly to reach this diagram. We have seen this diagram in the past as well. What steroids do, let's say dexamethasone, remember we talked about it. They work on almost all the immune system, and they would suppress a majority of the actions. So look at here, they suppress lymphocyte, eosinophil, basophil, monocyte production. So in the presence of steroid, all of those cell production will go down. And now the thing is, it's not that the bone marrow is not producing those cells anymore. Steroids can kind of eliminate those cells from uh, gravitating towards the area of infection. They just distribute them. So it's not that the cell production is released, it is just the cell availability is reduced. And this happens with a single dose of steroid like dexamethasone. Within 6 hours, the cells would start getting redistributed and becoming inactive and not available. And this effect can continue for 24 hours. Then the polymorphonuclear cells. These are the cells that have nucleus that has multiple lobes in them, eosinophil, basophil, and so on. These are increased in number. So they are released more from bone marrow, so they are increased in number. Adhesion. So steroid reduce the adhesion to the vascular walls. And the benefit of that is, we've talked about it many times before, that when a cell, let's say here is a blood vessel wall, and here is an infection, the immune system cells have to kind of hold on to the blood vessel wall, stop themselves as they're zipping through the blood. They have to hold on to the blood vessel, then come out of it, and then go to the area of the infection and work there. So the holding on to the blood vessel is called adhesion. Then coming out of the blood vessel is the emigration. And then walking all the way to the area of infection is called chemotaxis. So all of those functions are reduced and suppressed by steroids. So if you see here, adhesion is reduced, emigration is reduced, chemotaxis is reduced, phagocytosis, that is by the immune cell trying to eat the pathogen or the debris or the broken tissue, they reduce the phagocytosis. So all the activity of the immune system is going down. And respiratory burst, and we've talked about this even yesterday, we talked, when an immune cell eats up a pathogen, it puts that into a phagolysosome, which is, you can look at that as a hot tub, which is full of acids. And as we throw the acids and bleaches especially onto the pathogen, it breaks apart. And then that broken part is used, number one, we kill the pathogen, and number two, then that pathogen is exhibited on the MHC2 or MHC1. And that is how the rest of the immune system will become activated. So this area where we burn the pathogen is called respiratory burst. All of those actions are reduced by steroids. So they are immunosuppressant. And if now you keep in mind that in case of COVID-19 or in case of septic shock or acute respiratory distress syndrome, it is not the virus itself that we are trying to prevent or control. It is the runaway immune system which is just gone nuts. So steroids are, of course, going to help. So here they work, if you see, they work on the monocyte and reduce their activation. They work on the macrophages. That is the innate arm. We have been talking about the macrophage a lot. Macrophage eats up the coronavirus and then it would become active. And the activation process is that macrophage would connect with the naive T cell. There will be co-stimulation. The result is that naive T cell would either become a T helper 1 cell or T helper 2 cell. If it becomes a T helper 2 cell, then it would release interleukin 12. Sorry, I shouldn't say interleukin 12. This should be interferon gamma. So here, let me erase this. It would release interferon gamma, and that would activate the macrophage. So macrophage, look at how many functions steroids suppress in the macrophage. They reduce the arachidonic acid pathway. Remember, we talked about leukotrienes and prostaglandins. We'll talk about that in a second over here as well. Arachidonic acid derivatives are reduced, prostaglandins are reduced, leukotrienes are reduced. These are all one camp of cytokines, or not chemical substances. Interleukin 1 release is reduced, interleukin 6 release is reduced, tumor necrosis factor is reduced. And we know that interleukin 1 is very important to go and act on the brain to cause fever. Another important function of interleukin 1 is to go and ask the hypothalamic system to help produce more steroids. So here, when the interleukin 1 is reduced, more steroid production in our body is reduced from the suprarenal gland, and that is the basis of abrupt withdrawal. if we give external steroid in a large dose for a long time, even in a small dose for a long time, even for a week or 2 weeks, that causes our internal production of steroid system to be suppressed. So when you take this steroid away abruptly, that causes stress on the internal system to say, produce more steroid. An internal system cannot produce more steroid, and that can cause severe outcome. So here interleukin 1 is suppressed. Interleukin 6, remember we talked about interleukin 6, that it kind of activates almost a lot of the remaining immune system actions. So that is suppressed. Tumor necrosis factor has a similar thing. Then if you see here is a steroid that is sitting on dendritic cell and reducing the dendritic cell activity. So you would see almost every part of the immune system is reducing in its action. Here, for the COVID-19, remember we talked about it, macrophage connects with the naive T cell, then there is co-stimulation. The result of that is that in the presence of interleukin 4, the naive T cell becomes T helper 1 cell. T helper 1 cell then produces interleukin 4 and 5, which causes B cells to become active, and B cells produce antibodies. These are the antibodies that nowadays we are chasing all the time, saying where are the neutralizing antibodies? If somebody's plasma has that, do I have it or not? And so on. So these antibodies are the one that then go and these will bind with the coronavirus and neutralize it, hopefully. B cell is activated by T helper 1 cell. And when steroid is present, it blocks. So there is a gene in the T helper 1 cell that is called GATA3 gene, and steroid would suppress that gene. That would cause reduced production of interleukin 4 and 5, which would then cause the B cell not to be activated and our immune system would go down. Similarly, if you see here, if a naive T cell has interleukin 12 on it, then that would cause the naive T cell to become T helper 2 cell. T helper 2 cell would release interleukin 2, which would cause the cytotoxic T cell to become activated. We've done this discussion that cytotoxic T cell would then cause release of perforins and granzymes, and the cell that is virally infected, those cells would have holes in them, and eventually the granzymes would be thrown in through those holes and the cell would commit suicide and die. So this action is through the T helper 2 cell, and steroid has a gene in so there is a gene in T helper 2 cell called T-bet gene. Steroid would suppress that gene, which would then cause this area to become suppressed as well. So can you see how extensive is the activity of the steroid? And now let's just look at this as well. This is the discussion we've been doing for a few days. This is the inflammation. So not only the immune system is suppressed, inflammation is suppressed as well. So what is the mechanism here? Remember we talked about it, that in our cell membranes, we have phospholipids, and then these phospholipids are broken down by phospholipase A2 enzyme, which converts the phospholipid to an arachidonic acid. And then that arachidonic acid is worked on by cyclooxygenases and converts the arachidonic acid to prostacyclin, thromboxane A2, and other substances. And remember, we talked about these guys with the epoprostenol and so in the platelet discussions, PGI2 and thromboxane A2. So steroids, just looking at this side for a second, then arachidonic acid can also be converted to leukotrienes by lipooxygenase. Steroids can actually block this area, phospholipase A2 enzyme. So the result of that is the whole inflammatory system goes down, which is excellent when needed. We do not want the immune system or the inflammatory system to go down in the early part of the disease because we want these things to fight. But once they are fighting more than they need to be fighting, that is when steroids can come in and suppress them. So how do steroids do it? Steroids go to a cell and cause the cell to produce lipocortin 1. Lipocortin 1 then in turn blocks 5-phospholipase A2, and it can also block cyclooxygenase 2 and cyclooxygenase 1. So the result of that is that the inflammatory system goes down as well. So as you can see, steroids have such a huge effect. Now just some of the side effects. There is not sufficient time to discuss all the side effects of prolonged or high dose steroid use. Again, we are talking about steroids used in ICU and on ventilated patients. This is not a drug, especially in case of COVID-19, to take in the early part. It can be quite harmful. So let's look at the side effects. There are two types of side effects from steroids. One is the withdrawal of the steroid, that is somebody is using it and then we stop. Or the other one is prolonged use of supraphysiological doses. That is therapeutic doses that we are giving to treat someone. So on the withdrawal side, first thing is that if you withdraw steroid, then the underlying disease that you are treating may rebound. That is one. Then another is acute adrenal insufficiency. So suprarenal gland insufficiency can occur. Why? Because we had been giving steroids that suppresses the body's normal mechanism of producing steroids. Now when you take the steroids away, that normal mechanism is under stress. And when it tries to run fast, it can become insufficient, and that is the insufficiency that occurs. What can normally happen? We can have fever, we can have pseudotumor cerebri. So there can be an effect in the brain that looks like we have a tumor in the brain, but that is just the effect of steroid withdrawal. There can be myalgias, which are the muscle pains, arthralgias, which are joint pains, and generally the person can be malaise. That is from the withdrawal. Now, if steroids are used over a prolonged period of time, then what can happen? Remember, just recall their functions we just talked about. Fluid and electrolyte abnormalities, hypertension. Why? Because more sodium is preserved, more water is preserved, vasoconstriction occurred. That all would cause hypertension. Hyperglycemia, because glucocorticoids work with the glucose metabolism. They try to preserve glucose. They try to ask liver to make new glucose. They try to break down proteins to make glucose from them. The end result of all of that is increased glucose levels. So this is why when people have infections, they can have, even if they were not diabetic, they can have high glucose levels. And then people who are under stress, they can develop diabetes. So people who has virus or infection and were diabetic, their diabetes can become uncontrolled because stress can cause that, and steroids are produced from inside the body for stress. So if you're giving steroid from exogenously, that can also cause hyperglycemia. Then increase infection susceptibility. This is the point that steroids should not be used in the early part of COVID-19 because they would suppress the immune system, which would then cause other viruses and pathogens, including COVID-19, to grow faster because nobody is stopping them. So when somebody is on steroid therapy, they usually become susceptible to even more infections, especially also fungal infections. Then peptic ulcers can occur, osteoporosis can occur, myopathies, behavioral disturbances, cataract, growth abnormalities. Steroid use habitus, the body's shape changes. So fat is redistributed, as I said before. The fat would start redistributing on the upper part of the body, on the back, on the face, and above clavicles. Then stria would appear, the streaks on the body, and then ecchymosis or smaller, tiny hemorrhages can occur. That all with the steroid, and these are just a few of them. So with this, I'm back here. Hope you guys are doing good. We are on BitChute now, so that is a good news. What I'll do is that from today onward, or from 2 days earlier, every new video is going on BitChute plus on YouTube. So if YouTube keeps taking them down, we'll have them on BitChute. From a couple of days after, from this Monday, we will have made them free on drbean.com as well. I've been talking with my team. We want to keep this content free for you, so we will make it available on drbean.com for free as well. Maybe you'll just have to register and provide your email, but you would not have to give any credit card or payment information, and you would have access to this content for free. So this is the discussion for today. Tomorrow we'll continue to iodine. Please tell me what else would you like to discuss. Iodine is the last part in the Math Plus protocol. So with this, Thank you very much. Stay safe, stay happy, stay healthy. Please keep the people around you safe as well. And my request to you, please like, subscribe, and share this one. So thank you very much. Talk to you tomorrow.